So I think we want to have our Disruptive Dozen join us up here, please. Get out of your way once they... So I am privileged to welcome everybody to this year's 2019 Disruptive Dozen. This is always a really great part of this forum because it really highlights some of the exciting things that are on the horizon. My name is Jeff Golden. I am, as it says up here, the Chair of Pathology at Brigham Health and the Ramzi Cotran Professor of Pathology at the Harvard Medical School. More importantly, I want to introduce my co-chair, my co-moderator, Dr. Erica Shenoy, who's an infectious disease physician at the MGH and the Associate Chief of the Infectious Control Unit there at MGH, also an assistant professor of medicine at Harvard Medical School. And I'm going to let her introduce a little bit more about this Disruptive Dozen. So Erica?
Thanks, Jeff. So welcome, everyone. So how did we get to 12 individuals here as part of the Disruptive Dozen, or 12 technologies? So more than 60 in-person and telephone interviews were conducted with leading partners faculty. This took place over the fall. And then they met in November to hash out the details and find out who were the top 12. And so there's a series of key features of these technologies that got to the top 12. They include innovations that will have a strong potential to make significant advances in the field, but they also have to be technologies that are pretty close to making it to market. So the idea here is that these are high probability of deployment within the next couple of years. And so that's how we got to the 12 technologies today.
Great. So with that, we're going to start with the first video, and video 12.
Number 12, narrowing the gaps in mental health care.
In the United States, mental illness has reached epidemic proportions. Nearly 1 in 5 adults grapples with a mental disorder. Opioid addiction and misuse claim the lives of more than 130 adults every day. And antidepressant use among individuals 12 and older is around 13%, a figure that reflects a staggering increase of 65% over 15 years. Beyond medications, depression exacts a tremendous toll, with a total economic burden estimated at over $210 billion a year, more than double what the country spends on cancer. For the millions of patients with mental illness, access to quality, evidence-based mental health care can be life-changing. Yet significant barriers exist, ranging from social stigma to a dearth of available mental health specialists to high costs, which prevent patients from obtaining the care they need. Minimizing these obstacles is a top priority for the healthcare community. Now, several research teams across the country are harnessing technology, including AI-based methods, to help narrow the gaps in mental health care. One particularly exciting area of innovation is the integration of rigorously validated mental health methods into smartphone apps. For example, researchers in Massachusetts are developing an app for patients with opioid, alcohol, and other forms of drug addiction, particularly those with co-occurring mental illness. The app provides patients with a virtual form of integrated group therapy, or IGT, a highly effective treatment that teaches patients behaviors and skills to manage their own recovery and prevent relapse. The problem with IGT, it is both time-consuming and expensive, thereby limiting the number of patients a single mental health care provider can treat. By packaging the key elements of IGT into an app, which is now undergoing software development and will be tested later this year, the Massachusetts-based team hopes to significantly expand access to this vital treatment.
Great. So Eric and I have prepared just a couple questions for individuals in each of these different areas, and I'm privileged to introduce Dr. David Ahern, who's working in this area. And David, as you think about this, there's really a proliferation of these different apps for mental health care. What would you ask or what would you tell or advise a patient who's thinking about one of these apps? David?
Thank you, Jeff. As I think that video displayed, the promise and potential for digital behavioral health solutions and apps is enormous to address the gaps in mental health care that we have in the United States, in fact, across the world. However, with that said, I think the state of affairs right now is, frankly, consumer beware. We have virtually thousands of apps available to download, but very few, if any, have undergone any kind of systematic evaluation or rigorous testing. That is changing. That's the good news. And as we saw in the video, there's research now underway, and we're doing some in my laboratory, that's actually looking at the impact of these interventions delivered via smartphone, via mobile device, that has embedded in them evidence-based approaches to mental health care. And if you think about the challenge of delivering services to individuals with mental health problems, they're very stigmatized. There's the concern about access to care to diverse populations in particular. So once again, I really am very much an optimist that the future holds promise for these areas. The one suggestion I'd make to patients is, you typically would say, talk to your doctor. Unfortunately, doctors know less often than patients do about these apps that are available through the app stores. The American Psychiatric Association has developed an app evaluation model, which is well worth reviewing, and I would suggest patients to look at it. It talks about 4 areas that are really important. One is in privacy and security, and whether those devices, those apps have that aspect being addressed. The other is evidence. Is there any evidence that this is effective? Then there's the question of ease of use. And finally, interoperability. Does the information that is gathered, are you able to share that with your providers and use that information instrumentally? I think those are the features that are really important for patients to be aware of.
Thank you, David.
Thanks. So next we'll go to video number 11.
Number 11. Voice-first technology comes to healthcare.
Smart speakers now permeate homes in many parts of the world, taking on an array of routine tasks, from reciting weather forecasts to reordering cat food. According to a 2018 survey, nearly a quarter of U.S. households have a smart speaker, and of those, almost half own more than one. Now, this AI-powered voice-first technology is coming to the clinic, but its potential uses run deeper than simple consumer conveniences. Using speech recognition and natural language processing, several companies are developing tools that are designed to help clinicians deliver better care and also give them more of what matters: quality time with patients. For example, a host of healthcare technology companies are working on voice assistants that can help reduce physicians' data entry burdens. These tools can listen in on doctor-patient conversations and automatically convert the salient portions of the audio into a text-based doctor's note. Importantly, this text can be modified by the clinician if something doesn't look quite right. The information can then be automatically fed into the electronic medical record, lightening the load of clinician documentation, a major burden for physicians. Indeed, it is estimated that doctors spend roughly half of their day on digital data entry and less than a third with their patients. As exciting as these and other voice-first applications are, some significant challenges still limit the technology's wider adoption in healthcare. For example, the privacy and security of patient health information remains a thorny question. How to balance the convenience of AI-powered devices and the insatiable need for data to feed the machine learning process against the patient's expectation and right to privacy. In the meantime, healthcare technology companies are developing applications that can run on consumer-grade voice technology platforms while complying with the Health Insurance Portability and Accountability Act, or HIPAA. As the industry moves towards a new era of HIPAA-compliant devices, the groundswell of enthusiasm around voice-enabled healthcare technologies will likely intensify even further.
So we have Dr. David Ting from Mass General. So David, aside from the issues of privacy and security, what do you think are the major barriers that our leaders are facing in terms of getting this sort of technology into the clinic?
Thanks, Erica. Alexa, can you please scroll through my notes and pull up my remarks for this morning? And by the way, bring me a pizza with anchovies. So we're almost there, but as you've pointed out, there are a couple of barriers still to broad adoption and really the next steps. We're excited that we can overcome these. I think of them in two broad categories. The first category of barrier being the training of the AI, the machine language, and the second being changes in workflow and culture. So in regard to the training, up to now, the early generation AI solutions have largely been trained in an unsupervised way. So we bring in as much data as we can, let the machine sort it through, and out comes the answers. In natural language processing, in voice assistance, in voice technology, now we're talking about human communication. And everyone recognizes that the way that humans communicate is not exactly as predictable as, let's say, looking through imaging studies where it's fairly known what the bits and bytes on the screen might reflect. And so that means that we need an enormous amount of data to train the next generation of voice assistants and voice-activated solutions. In the video, we pointed out that the barrier here is going to be with the current privacy rules around HIPAA, data sharing, data governance, and data ownership. It becomes a little bit complicated. How do you bring in so much data to train the AI without starting to step over the privacy rules and privacy expectations of our patients and our providers? But related to that, it's not just a matter of the volume of the data, it's actually the scope of the data we bring in. Again, any clinician in the room knows that in the exam room, it's not a linear progression of saying one thing to the patient and then the doctor responds. There's really a back and forth that's pretty uncurated. And so I really challenge our industry partners, our innovators throughout the environment to work with clinicians to supervise the training of the AI, to annotate the AI and train in a way that's intelligent, that guides and accelerates the machine learning.
Thank you.
Great. So if we could get video number 10.
Number 10, the hidden signs of intimate partner violence.
Each year, millions of people experience violence at the hands of an intimate partner. Globally, intimate partner violence, or IPV, ranks as the leading cause of homicide-related death in women. In the U.S., over half of women murdered each year are killed by a current or former intimate partner. The healthcare community can play a vital role in reducing the devastating impact of IPV. Studies show that women who are victims of IPV seek medical care more often than non-abused women. And importantly, that healthcare providers represent a trusted source for divulging abuse. While screening for IPV can help detect and prevent future violence, particularly in emergency departments, it falls short. Roughly 80% of IPV cases come through the emergency department, yet less than 30% are appropriately flagged as abuse-related. Recognizing the need for better approaches to IPV in healthcare settings, researchers are working to develop AI-enabled tools that can help alert clinicians if their patients' injuries likely stem from IPV. For example, a team in Boston recently conducted a pilot study that analyzed the electronic medical records and imaging exams of nearly 200 patients with a known history of IPV, along with a control set of over 550 non-abused patients. They discovered that the vast majority of IPV victims were women with a mean age of around 34 years. Also, those experiencing IPV underwent 4 times more medical imaging tests than the control group, with a higher incidence of injury to the upper face and extremities, as well as obstetric and gynecological problems, such as bleeding, miscarriage, and delayed fetal growth. Now the team is working to expand this initial study. Through their AI-enabled system, they hope to help break the silence that surrounds IPV by empowering clinicians with powerful, data-driven tools that can better recognize its physical signs.
So we're honored here today to have Dr. Bharti Khurana from the Brigham Health Radiology Department. And Bharti, I was just wondering, what really resonates with you about these automated methods that will help us detect IPV IPV, and what are going to be the big obstacles?
Thank you, Jeff. As you just saw the video, our goal is to predict IPV risk probability for every patient based on historical, clinical, and imaging data, not just on the current visit. So as a radiologist, I'm very excited because this is the platform which is giving me to provide value instead of simply reporting the injuries. And of course, it's giving robust tools, robust data-driven, powerful tools to the clinicians and social workers to approach the patient with confidence without worrying about offending the patient or the spouse. There are, of course, challenges with this automated tool. So our clinical decision support rule is based on proven IPV victims and control groups. And this control group, unfortunately, will have those patients who are victims of IPV, but they are not forthcoming. So those are actually false negative. And of course, that would affect the sensitivity for any predictor. However, it shouldn't be really affecting the specificity. And as more and more we do these cases and our testing and validating cases get better, the goal is that it would become better with sensitivity as well. The other concern is that it's quite likely that our alert system will be false positive in some patients. For example, a patient who is sustaining recurrent injuries not really related to IPV. And in those cases, even if there is alert, it would require the clinical team and radiology team to discuss and override the alert. And even if, let's say that we don't override, it's okay. It's reasonable to have a caring conversation with the patient and make them aware of available resources for IPV. Because unlike children, in adult victims, they are not forced to leave their spouses against their wishes. And it's good. It has some preventive aspect too. So the patients who are not really going through abuse, but they are prone to abuse, they would definitely get benefit out of that caring conversation. So thank you.
Thank you.
Video number 9.
Number 9, a revolution in acute stroke care.
Stroke is a major cause of death and disability across the world and a significant source of healthcare spending. Each year in the U.S., nearly 800,000 people suffer from a stroke, with a cost of roughly $34 billion. The lion's share of this burden comes from the type of stroke that stems from a lack of proper blood flow within the brain, so-called ischemic strokes. When a patient comes to the emergency room with a suspected ischemic stroke, time is of the essence. It has been estimated that on average, for each minute a stroke is left untreated, nearly 2 million neurons are lost. However, there is substantial variation among individual patients in terms of when and how many neurons will be lost. A landmark study published just 2 years ago revealed that a subset of stroke patients may have more time than previously thought, up to 24 hours. This represents a dramatic shift in clinical thinking, one that has sparked a sea change in stroke care and opened up new opportunities for AI-driven innovation. When a stroke is suspected, clinicians typically order a series of brain imaging tests to pinpoint the source of trouble. These diagnostic steps are critical. A misstep, especially early on, can be fatal. Several research groups are now creating AI tools to help automate this diagnostic journey. For example, a research team in Massachusetts has developed a set of AI-based algorithms that can help determine whether or not there is bleeding within the brain, a crucial early insight that helps doctors select the proper treatment. These algorithms can automatically review a patient's head CT scan to identify a cerebral hemorrhage, as well as help localize its source and determine the volume of brain tissue affected. The societal implications of these tools are significant in terms of both the number of patients who stand to benefit from them, as well as the potential savings to the healthcare system.
So I'm pleased to introduce Dr. Gil Gonzalez from MGH Neuroradiology. So Dr. Gonzalez, when do you think these technologies will be available nationally and even internationally?
Thank you very much for that question. We are indeed in the middle of a revolution, and it's a revolution of the most severe, in treating the most severe ischemic strokes. These are people who are very ill, and we can literally bring them back to complete health if they're if they get the proper treatment. And But the problem is there's a couple of big mismatches. We can treat these people at major centers like the General or the Brigham and in major cities. However, stroke occurs across the entire country in every nick and cranny, every part of the country. There is a match, though. There's CT scanners right where all these patients are. But there's a second mismatch. These CT scanners may not have, the people that run the scanners may not know how to get the right sequences or have people available to interpret them. So our AI program is geared to correct these two mismatches by putting in technology or putting in intelligence in CT scanners throughout the world, literally, to identify the proper patient who would benefit from treatment and ship those people to places like the General or the Brigham to treat them. How far along are we? There's 5 key imaging algorithms that are being developed by the Center for Clinical Data Sciences at our institution, as well as other investigators. As we speak right now, the first one is being implemented in the MGH Emergency Department, and we will be implementing all of them over the next several months. Simultaneously, we're working with GE Healthcare. They will be adopting these algorithms, and later this year, towards early next year, they will be tested throughout this country and in the UK with the idea of spreading these algorithms throughout the world.
Terrific.
Thank you. Video number 8.
Number 8, reducing the burden of healthcare administration.
The technological reach of AI in healthcare is not limited to the clinic. In fact, some of the most significant improvements in healthcare efficiency could be realized, at least in the short term, through the use of AI to automate routine and highly repetitious administrative functions. In the U.S., more than 25% of healthcare expenditures are due to administrative costs, far surpassing all other developed nations. One important area where AI could have a sizable impact is medical coding and billing. In the U.S., a complex system of numerical codes is used to document what diagnoses an individual patient has and what treatments or procedures have been rendered by the care team in order to coordinate payment with insurance companies. Often, physicians themselves will enter these codes. Other times, a team of dedicated coders handles the task. Either way, the administrative infrastructure of medical coding and billing in the U.S. is both complex and expensive, fueled in part by the financial risks for the providers. Billing mistakes can result in lost revenue. They can also trigger expensive audits with hefty fines and, in the worst case, charges of fraud. Ultimately, the entire healthcare system bears the cost of this highly complex administration. To help streamline the process of medical coding, teams across the country are harnessing AI to develop automated approaches. For example, a Boston-based startup has created a suite of machine learning algorithms that can analyze the doctor's notes from patients' electronic health records and can automatically generate the proper diagnostic and procedure codes. So far, these tools have performed well across a range of medical specialties. The ultimate goal is to help reduce the complexity of the coding and billing process through automation, thereby reducing the number of mistakes and, in turn, minimizing the need for such intense regulatory oversight.
There's really no one better to discuss this topic than Dr. Jim Heffernan from MGH. And Jim, I wonder, we just heard about the advances in coding. Are there other areas of healthcare administration where you see AI really having an impact?
Jeff, that's a great question. I actually think there's numerous ways, but maybe behind your question is there a way to return the electronic medical record to the clinician as opposed to being the purview of the administrator and billing side? When we set out to develop a coding tool, it was really aimed at reducing the administrative burden on physicians. If you look at our surveys and any public survey, in almost every survey, in the top 5 is completing the medical record. And it's really not completing the medical record for clinical purposes. It's completing the medical record to get the diagnosis in the right place or this particular piece of information into the note. And so what we're striving to do is, first off, get physicians out of doing the coding itself within the next 5 years, and we're making good progress in that. But the tools, whether it's NLP or structured and unstructured data analysis or machine learning, particularly using domain adaptation, is apply them to, for example, authorization processes. There's no reason we can't take all the information that's already in the medical record and in that way create a document that can go to the payer that's already established. Not only is that faster, it also reduces the gaming that takes place in this whole process. So now you have an opportunity that's even better for the payer because they can see how you're pulling that information and reduce both our cost and their costs. At some point in the future, we might even have a situation where physicians are individually goal-carded because everything they send is always appropriate. Just imagine that kind of situation. So I think there's a lot of opportunities. I really think that our goal is to return that the clinical purpose of the medical record is number one. The epidemiological reasons is number two, and that includes all the quality and safety type of stuff. And then the billing and administrative stuff becomes number three.
Great, thank you.
Video number 7, please.
Number 7, lighting a fire under health information exchange.
As the U.S. healthcare system has grown in complexity, the flow of clinical information has also become more complicated. Today, these challenges are on display when a patient requests copies of her own health records and days or weeks later receives a stack of printed or faxed pages in return, even when those records are stored electronically. The exchange of health information is, by necessity, a complex, multi-step process. For example, within a single healthcare organization, multiple administrative systems, like scheduling and billing, must send and receive information from various clinical systems, ranging from laboratory services to radiology. Within the vast universe of healthcare data, a major driver of complexity is the lack of standards for how information can be shared between disparate systems. But now, the tides of healthcare information technology are turning. A new data standard, known as the Fast Healthcare Interoperability Resources, FHIR for short, has become the de facto standard for sharing medical and other health-related information. With its modern, web-based approach to health information exchange, FHIR promises to enable a new world of possibilities rooted in patient-centered care. Already, FHIR is having a noticeable impact. For example, in some healthcare systems, patients can connect to their provider's online portal and have critical pieces of their medical records transferred to a special smartphone app designated for personal health information, which can then transmit relevant details to other health-related apps, like one for managing different prescription medications. While this new world is just emerging, it promises to give patients unfettered access to their own health information, allowing them to decide what they want to share and with whom. It will also demand careful consideration of data privacy and security, as sensitive data will be exposed in ways it wasn't before and made vulnerable to theft and misuse.
So we have Sandy Aronson from Partners Healthcare System. So Sandy, I keep asking the when is this going to happen question, so I'm going to ask you that question. When is the approximate time you see this to actually having a meaningful impact?
Yeah, it totally depends on a relatively small community of individuals and organizations of which everyone at this conference, literally everyone at this conference is a part, on the decisions we make to advocate for, build, and demand open interfaces and open business models. The dream here is that FHIR starts out relatively small number of data types as it is today. EHR companies and others build interfaces based on those data types. Apps get built based on those interfaces. Feedback happens from those apps that makes the interfaces and the underlying standards more robust. They grow, they enable the apps to be distributed. The apps wind up collecting data in more and more places consistently. That data gets shared in a way that enables greater use of machine learning. We wind up with more learning in healthcare, leading to a continuous learning healthcare environment, which delivers the greatest improvements to human health that we've ever seen in history. That's the dream. We actually are while at the very beginning, we're at a good place relative to to the start. We're seeing, allergies, drug allergies, soon better support for that. Platelet management, already better support based on these interfaces there. If we all row in the same direction here, I think there's a real possibility, 3 to 5 years, we have fundamental improvements to the healthcare system, but this story is not written yet. Everyone here has a pen, so please try to think about how you can use that to your best advantage.
Thank you.
Thank you, Sandy. Okay, video number 6.
Number 6, AI, artificial intelligence for eye health and disease.
Clinicians often monitor eye health through detailed, three-dimensional examination or imaging of the retina at the back of the eye, using photography, optical coherence tomography, and other modalities. Here, the retina may indicate troubling signs of disease, like swelling, blood vessel leakage, bleeding, or abnormal growth. If left untreated, these conditions can result in vision loss. Yet examination and retinal images can be difficult and time-consuming, requiring clinical expertise, expensive equipment, and skilled personnel, making it difficult for patients to access and to receive proper care. Now, just as in other imaging-based medical specialties, AI is helping to usher in new approaches in ophthalmology that promise to improve patient care. In 2018, the Food and Drug Administration took a historic step with the approval of a new AI-based system for the detection of diabetic retinopathy, a diabetes-related eye disorder that can result in blindness. The move was noteworthy because it marks the first fully automated, AI-based diagnostic tool to reach the market in the U.S., one that does not require additional expert review and is therefore suited for use in primary care and low-resource settings. It also represents a potential advancement in care for a condition that affects a large swath of people worldwide. In the U.S. alone, over 30 million people live with diabetes, and roughly 24,000 a year experience vision loss due to diabetic retinopathy. More than half of patients with diabetes do not seek regular eye exams. A large prospective study of this AI diagnostic system, involving 10 primary care clinics and more than 800 patients with no prior history of diabetic retinopathy or diabetic macular edema, found that it exceeded the accuracy benchmark set by the FDA. The findings help underscore the capacity of AI-enabled technologies to enhance primary care with specialty-level diagnostics, making it possible to more rapidly identify patients in urgent need of specialized care, especially in low-resource settings where access to expert ophthalmologic care is limited.
So I'm delighted to introduce Dr. Joan Miller from the Massachusetts Eye and Ear Institute. And Joan, I wonder, as you think about the clinical implementation of these various tools and how they've unfolded, if you can kind of share what that's been, and also, what's the response been from both the clinicians but also the patients?
Thanks, Jeff. Well, it's very exciting to have an application achieve FDA approval, and I think that's a great sign. And there is a lot of work going on in this field. But to date, there's really been somewhat limited deployment, and I think it's worth looking at the barriers, which actually I think we can overcome in the next couple years. The first is that the cameras that are being used are still expensive. They have a footprint, and there is an effect on the workflow. And in our own experience trying to deploy cameras that we actually purchased, the primary care docs don't want to have anything to do with it. And I think that will change over time. The cameras will get smaller, cheaper, easier to use. I think we can think about ways to not adversely affect workflow. You can actually envision use of these cameras and OCT devices in storefront capacities where patients could go and be imaged at their convenience, receive a report generated by the algorithm, and figure out if they need to be seen and how quickly that needs to happen, and ideally that information also flowing back to the provider. So I think there's a lot of anticipation and excitement on the horizon, and lots more to do with this. I think we see a lot of interest in application in diabetic retinopathy, but there are other retinal diseases that certainly can have some approach here also, including macular degeneration, also optic neuropathies like glaucoma. So a lot of things in the eye, we really hope to lead the way on this. Thank you.
Great, thank you.
Great, thanks. Video number 5.
Number 5, a window on the brain. toward real-time monitoring and analysis of brain health.
Today, doctors can stand at a patient's bedside and watch the electrical activity of the brain in real time. But the complexity and sheer volume of these measurements, known as electroencephalograms or EEGs, mean there is often a gap between when measurements are made and when diagnoses are rendered. But now, deep learning tools are making it possible to automate the analysis of EEGs and other high-frequency waveforms, so clinicians can rapidly detect electronic abnormalities that signal trouble. And that power is enabling a new world of real-time monitoring of the brain that promises to dramatically improve patient care. One area where these new tools are gaining traction is seizure detection in critically ill patients. These seizures are often devoid of any outward signs, such as convulsions, making EEG the only reliable means of discovery. So patients often receive continuous EEG monitoring. Clinical experts examine the EEG recordings manually through a painstaking analysis, searching for telltale signs of a seizure. Yet because of its resource-intensive nature, this review happens intermittently and typically only during the day. That means if a critically ill patient has a seizure overnight, it may go unnoticed until the next morning. Over the last decade, a team of researchers in Boston has annotated some 30 terabytes of EEG data from thousands of patients. They have mined these data to create deep learning algorithms that can automatically detect seizures in the critically ill, regardless of the underlying cause of illness. These tools are now under development and will be deployed in the coming year at a large hospital in the region, making real-time analysis of EEG a clinical reality.
So we have Dr. Brandon Westover from MGH Neurology. So Brandon, how can you, when this gets deployed in the next year or so, how will patient care be different today versus a year from now?
Right, so right now we monitor for almost everyone in the hospital gets monitoring of their kidneys, their lungs, their heart, and we mostly ignore the brain unless there's a special need, someone suspects seizures. And in patients where we do EEG and those ones who we are asked to, we find seizures in 30% of those patients. So these are mostly quite ill patients. The surprising thing is many of them don't have any brain injury. This is kidney failure or liver failure. So I think in a year we'll be catching a lot more of these seizures. We'll be able to do it with algorithms that can run continuously, like the video mentioned. These can happen overnight. The more concerning thing is sort of more ambiguous patterns that if they go on for a long, long time can damage the brain just in the same way that seizures do. So part of what the AI is letting us do is understand better where the line needs to be drawn, where we need to pay attention and treat, or just kind of watch and wait and see if anything worse happens. In addition to seizures, though, there are a lot of other problems that brain monitoring can help us with. Delirium is one that is a big underdiagnosed problem. It's usually missed until it's out of hand. And low footprint brain monitoring and automated analysis is one way that we can help diagnose that earlier. There are patients in the ICUs who have strokes that we know are going to happen. About half of them with certain conditions have strokes. We know that we can recognize that visually, but with computer algorithms, we should be able to do that automatically. So I think there's a wide range of brain monitoring applications we'll be able to serve patients with that we just can't do right now because it's too manual and labor intensive.
Video number 4.
Number 4, automated malaria detection.
For roughly half of the world's population, the threat of malaria infection is ever present. According to the World Health Organization, there were roughly 219 million cases of malaria in 2017. Nearly 500,000 people succumbed to the disease, with children under 5 making up the vast majority. A major challenge in malaria control is diagnosis. From a clinical perspective, simply knowing that the malaria-causing parasites are present in a person's blood is not enough to properly manage the disease. That is why microscopy is often the diagnostic tool of choice. A pathologist peers down the barrel of a microscope to visualize and manually count the malaria parasites that lurk within a drop of blood smeared on a slide. It is a slow, laborious, and often difficult process that requires skilled training. Expertise often lacking in areas hardest hit by malaria. Now, with the help of deep learning, researchers in Washington State have developed a software program to help automate malaria diagnosis. Their tool can detect and quantify malaria parasites with 90% accuracy and specificity, matching the performance of human experts. The researchers packaged their algorithm within an inexpensive, automated digital microscope, which has yielded impressive results in field tests, both in Thailand and Peru. The system continues to undergo further field tests and is now in commercial development. Such an automated approach to malaria detection and diagnosis could benefit millions of people worldwide by helping to deliver more accurate and timely diagnoses. In addition, as drug-resistant forms of malaria continue to surge in some countries, including strains that can withstand frontline drugs, these methods could enable better monitoring of treatment efficacy. That, in turn, will help the global health community to more vigilantly safeguard the potency of the world's anti-malarial medicines.
So we are delighted to have here Rochelle Walensky, who is at the MGH. And Rochelle, I wonder if you could talk a little bit about how these tools have improved malaria diagnosis, particularly in those areas that are hardest hit.
Great, thank you. I think we all recognize malaria as one of the global infectious killers, one of the leading global infectious killers, and it is disproportionately impacting resource-limited settings where care is really hard to access. The one thing I think is important is that current rapid diagnostics have to be inexpensive, right? So we have 300 million rapid diagnostics that were rolled out in 2016 for malaria. The other thing that they have to be is accurate. So the current gold standard here in the United States is to use the microscope, as was said. The microscope is labor intensive. It requires expertise, and importantly, it requires a power source. You need a light. And so we need a rapid diagnostic that won't require all of those things, but that is accurate. The current rapid diagnostics, unfortunately, if you have a patient that presents with malaria, and the current rapid diagnostic is negative, then in fact, you don't have enough confidence in that diagnostic test to withhold treatment. So the fact that we can have something that's accurate and rapid and inexpensive all at once, I think is really exciting. And then the third thing that I think is really important is quantification. Under the microscope, we can see how many parasites are there, and when we take care of patients with malaria, we not only follow them clinically, but we follow their level of what we call parasitemia, how many parasites are in the blood. The current rapid diagnostics, unfortunately, are a qualitative test. They just say yes or no parasite, but this exciting new innovation could actually tell us how many are there, and then we can sort of track the level of parasitemia in the field, which will allow us to follow the patient clinically as well as the level of parasitemia. That gives us some indication as to how effective our treatment is, and that then we can sort of get a sense as to whether we are worried about resistance in that setting. And then the final thing I'll just mention is that this platform allows for potential technology to detect other things that we need to look for in the blood, things like trypanosomiasis that causes Chagas disease and filariasis that causes deformation and lymphatic drainage. Thank you.
Video number 3.
Number 3, streamlining diagnosis.
Over the last decade, clinical imaging has become increasingly digitized. First with radiology, now a fully digital practice, and more recently, pathology, which is now beginning to embrace digital technologies. This evolution is paving the way for computer vision and other AI-based approaches, which are spurring some important changes in how diseases are detected and diagnosed. One area of change is clinical workflows. With AI, clinicians can prioritize patients' images for analysis, essentially move them to the top of the virtual stack, based on the likelihood of an abnormal and potentially life-threatening finding. For example, researchers in California recently developed a deep learning-based algorithm that can distinguish normal chest X-ray images from abnormal ones. Rather than search for just one type of abnormality, the tool simultaneously scans for up to 14 different conditions, including pneumonia, pneumothorax, enlarged heart, and lung nodules. It performed as well as radiologists in diagnosing a majority of these conditions and could analyze images in a fraction of the time. Incorporating such a tool into radiologist workflows could enable them to read patients' images more quickly and efficiently. Similar AI-based tools are also under development in pathology. These tools could help prioritize or screen patient cases according to the presence of cancer cells or other urgent findings, clarify borderline diagnoses, and integrate pathology findings with other clinical and laboratory data. including vast molecular data to support the diagnostic, prognostic, and treatment decisions that clinicians make while caring for patients. These and other innovative image-based tools are ushering in a new era of AI-enabled disease diagnosis, one that amplifies the collective expertise of radiologists and pathologists, empowers them to work with greater precision and efficiency, and provides better integration across the healthcare continuum, all with the aim of providing better care for patients.
So we have Dr. Annette Kim from the Brigham Pathology Department. So Annette, it sounds incredibly exciting. I'm wondering how this is going to change what the pathologist does in daily practice.
So I think the bottom line is that pathology is at the center of diagnosis, and the diagnosis, of course, underlies a huge percentage of all of patient care. And so at that center, at that pathology center, we're integrating a huge amount of data that funnels through us, whether it be what we're looking at under the microscope or the number of ancillary tests that we use, including looking for expression of various biomarkers and molecular genetic abnormalities, and also other laboratory findings, radiographic findings, and clinical history. We're incorporating all of this together to come to the diagnosis. As the number of things is increasing that we need to integrate, unfortunately, this is impacting our time. And so we're increasingly becoming strapped for time, and I think this is where AI can really have a huge impact on our practice by allowing us to use our limited time in the most meaningful manner. And so there are sort of three ways in which I think AI is and will be influencing the practice of pathology. The first is simply in obviating the need for pathologists to spend a significant amount of time doing relatively menial tasks, whether it be counting cells, counting parasites, measuring depths, estimating fractions, and even in the area of molecular, for instance, discriminating noise from true variants. These are all things that we spend a lot of time doing that AI has already been instrumental in limiting our efforts in that area. It also helps us prioritize cases, as was mentioned in the video. This is an area which is going to be increasingly coming in the next 3 to 5 years, where every day we get a huge stack of patient samples that we have to assess. And buried in there might be something very, very important that needs to be acted upon immediately, and that will require a number of ancillary tests. This will allow us, using machine learning, we can identify those abnormal cells, for instance, cancer cells or abnormal molecular findings, and have them pre-screened and flagged for us so that we can prioritize the review of those cases and get those ancillary studies going as quickly as possible. And then ultimately, I think the way that the AI is going to really support pathologists is in our role as the integration experts. We are the ones that bring together all of this vast quantity of data and bring it to bear on making a diagnosis. And I think that's where AI can help us in making sure that we don't miss something buried in the electronic record, make sure we can flag discordant data, and then help us recognize individual patterns of disease, some of which we may be using now already in our brains, and others of which may be yet to be discovered. And so all of these will help us improve cost-efficient medicine, patient safety, and improve diagnosis and quality of interpretive comprehensive diagnosis.
Thank you. As the Chief of Pathology, I appreciate that. So video number 2.
Number 2, better prediction of suicide risk.
Suicide is a vexing problem, particularly in the U.S. It ranks as the 10th leading cause of death. Even more alarming, suicide is the second leading cause of death among young people. In 2016, there were 45,000 suicide-related deaths in the U.S., twice the number due to homicide. For doctors, figuring out which patients are at risk of self-harm remains a major challenge. Clinical methods for flagging suicidal patients remain extremely inaccurate. And while conditions like depression and anxiety are often precursors to suicide, more than half of the individuals who attempt suicide have no prior history of mental illness. Now, researchers are leveraging AI-based approaches to help counteract this worrying trend. For example, 2 Boston-based teams have mined the information in patients' electronic health records to help identify which patients are at risk of suicide. In one study, it was possible to predict nearly half of all suicides and suicidal behaviors with remarkable specificity, and importantly, well in advance of patients' self-harm. As encouraging as these efforts are, they are only first steps. The studies must be replicated using additional patient datasets, especially those from other healthcare systems, in order to determine the tool's broader applicability. Meanwhile, various teams across the country are focusing their attention on perhaps the most tragic problem of all, teen suicide. Instead of analyzing electronic health records, researchers are examining social media content with the goal of detecting early warning signs of suicide. For many people, particularly youth, their interactions with social media are much more frequent and sustained than their interactions with the healthcare system, making this area ripe for investigation. Yet these efforts come with some significant ethical and privacy concerns, issues that must be carefully weighed as the medical establishment and society at large grapple with how to prevent suicide. If you are thinking about suicide, there are organizations you can turn to now for help. Call the National Suicide Prevention Lifeline at 1-800-273-8255, TALK, or visit speakingofsuicide.com/resources for a list of additional resources.
So someone working in this very important area is Dr. Tom McCoy from the MGH. And Tom, as we just heard, there's many ethical and privacy concerns. Can you maybe elaborate on what some of those are? And as these tools are being developed, how are those being addressed?
Yeah, it's a great question. It's a question that I've heard, I think, every day of the forum, regardless of the clinical setting. In a way, I think that's the most encouraging part. We're thinking broadly about the issue, and that's the sort of deliberative progress that I hope society should expect from the academic medical enterprise. Whether it has a specific relevance to psychiatry is another in the long chain of questions about psychiatric exceptionalism. And I think the answer there is that there are real reasons to believe that it is exceptional and real reasons to hope that it won't always be that way. So how do we move forward given that we have ambitions for the world to be different than it is? And that has to do with really hazard analysis, something that we're familiar with in medicine already. When we think about our health records-based research, we're not actually collecting new data on our patients. We're just making better use of the data we already have. I think that's really something that our patients expect of us as is. I'm yet to find the patient who's been surprised that we're trying to do more with the information we already have. The surprise is the privacy concern. The minute we have data or do things with data that surprise our patients, that's time to step back and think more deeply about it. The ethical ramifications are actually more problematic in many ways. That's going to have everything to do with what we do with the technology. And what we do is entirely under our control. We're going to need to find ways to transform the way we deliver healthcare to make sense out of a biased coin. These classifiers are far from perfect, but they are better than chance, and they're better than our not-so-gold standards in routine clinical practice. So it's really on us to come up with ways to change the way we deliver care to capture that additional value to solve this pressing public health problem.
Thank you.
Thank you. Video number 1.
Number 1, reimagining medical imaging.
Medical imaging technologies have been in clinical use for decades. While these methods are widely used, X-ray forms the basis of mammography, which is used to screen millions of women each year for breast cancer. They are imperfect. Now, bolstered by AI-enabled approaches, research teams across the world are working to enhance these fundamental technologies, making them smarter, more sensitive, and more accessible. For example, researchers are using AI-based approaches to increase the power of mammography, transforming it from a one-size-fits-all method to a more targeted tool for assessing breast cancer risk. A team in Massachusetts has developed an AI-based method that can automatically determine breast density using mammograms. Dense breast tissue obscures tumors on mammography and can also independently raise a woman's risk of developing breast cancer. Moreover, radiologists' assessments of breast density are subjective and can vary widely from one reader to another. The new AI tool was used to screen over 10,000 patients in routine clinical practice. Its density assessments were accepted by experienced radiologists in 94% of cases. Now, the team is enhancing their AI-based system, incorporating both clinical and breast imaging data to give individualized assessments of breast cancer risk that can automatically flag patients for follow-up tests, such as an ultrasound or MRI. Over the next few years, they hope to make mammograms more like pap smears, which are now read by automated systems in many parts of the world to screen women for cervical cancer. Researchers are also harnessing AI to enhance other imaging methods, including ultrasound. By broadening the utility of this technology through an assortment of new AI tools and applications, this relatively inexpensive imaging method can bring improvements in clinical care to patients around the world.
So I'm pleased to introduce Dr. Claire Tempany of the Brigham. So Claire, can these AI-based tools really live up to what we're seeing here, which are enormous expectations?
Thank you, Erica, for that question. And thank you for acknowledging the role of AI in imaging. I think we've heard already from two of my colleagues in radiology what an impact it's making. We certainly feel the onus on the radiology community and all of its affiliated sciences to make sure we do deliver and translate this into really improved healthcare for all our patients. One just representative example is that all of the imaging societies have opened their doors to the AI adventure, so to speak, insofar as example one being the RSNA, the Radiology Society of North America, meets every year in Chicago, and about 60,000 people come to that meeting. The square footage of the density space taken up by AI companies is going to double, they expect, every year. So the radiology community is really embracing this and really anxious to learn, first of all, develop and co-work with all of the industry partners to translate these technologies into real valuable tools. And you've seen some examples already today on how AI is impacting radiology practice. It really impacts the entire image life cycle, from the minute a doctor and patient agree to an imaging test to the report being brought back to that patient and doctor scenario. And so really looking at the role, it's in many, many different places, like in behind the scenes in determining when to read and prioritize a high-risk scan. So we really do see this as being incredibly important. Can we live up to this enormous expectation? I think there are some little clouds on the horizon with that. Certainly trust, expectations, and understanding what the algorithms are delivering. I think it was well said yesterday that many of these algorithms are in black boxes. They need to become glass boxes and transparent so that we can understand how they're working. We have to believe in the data before we can obviously start using it. But we desperately need it. We are overburdened, as you've already heard. The exact same story in pathology. There are not enough radiologists. We also want to equalize care across the world. We want to be able to have radiologists who are not subspecialized become subspecialists very quickly. So we're very optimistic and very excited and look forward to learning more about this. Thank you.
Great. So on behalf of my co-moderator, Erica Shenoy, and myself, I want to thank our panel for a really exceptional discussion. And I hope from all of you in the audience, you've heard throughout this forum from really leaders in the field about the innovation that's happening in AI, the vision that is happening. And today, I think we've heard a little bit of really what's the boots on the ground, what's actually happening now, and what over the next year is likely to have an impact in the healthcare arena. So thank you all very much.